Welcome, everybody. My name is Bill Kimler. I'm the chair of the Greenwood County Democratic Party, and I welcome you to our February event for our community care movement. I'm going to turn the reins over to Mrs. Wanda Moore here shortly, but I welcome all of you who joined us. We are looking to increase community involvement, community health, community activism. And we are delighted today to have as our keynote speaker, Dr. Paul Kim, who's going to go through a whole series of great information, some of which could save a life. So without further ado, Miss Wanda, would you kick us off, please?
Good morning, everyone. Heart Health Awareness, Saturday, February the 20th, 2021, 10 a.m. Mr. Bill Kimler, chairperson for the Greenwood County Democratic Party. Ms. Cheryl Morton, founder of Finding Me Women Ministry. I am Wanda Moore, the Community Care Movement Director, and I will be presiding. We will have Welcome and Purpose, Ms. Cheryl Morton.
Hello, everyone. I hope everyone is doing well this morning. Thank you guys so much for tuning in. Thank you so much for having me to be a part of this wonderful event. I'm just so excited, and I want to welcome everyone to the Zoom or Facebook Live, however you're coming on. I want to welcome you guys, and we want to thank Dr. Kim for sharing this awesome information about heart health, because so many people are dying from the heart disease, especially our women. We look at statistics. Statistics tell us that women suffer from heart disease in rapid numbers. So we are so excited about these guys are giving us this information and want to share this great information so that we can live, so that we can have great life, and so that we will know exactly what it is that we need to do to help ourselves. So welcome you all to this wonderful, beautiful Zoom and Facebook Live, and thank you so much for all of you guys for tuning in.
Thank you for having us.
Dr. Kim, we're going to go up to you. Actually, we'll start with an introduction from your lovely wife, Ms. April Timonelli.
Good morning, everyone. Thank you for joining both on Zoom and Facebook Live. It is my pleasure to introduce Dr. Paul Kim. I'll give you a little background story. He was born in New Jersey and to parents who had immigrated from South Korea in the late 1960s. He grew up in Galveston and Houston before attending the University of Texas in Austin. He then graduated. He attended Baylor College of Medicine in Houston, where he was chief residency as internal medicine at the University of Texas and at the Baylor College of Medicine as well. He did his cardiology fellowship at the Texas Heart Institute, after which he was recruited by some of you who have been longtime people in Greenwood know. Dr. Ennis James recruited him to come and establish the interventional cardiology program here itself. That was back in 2002, and he has been here ever since. And it's my honor to introduce Dr. Paul Kim.
Thank you, April. So I appreciate the honor and the privilege of being able to present to you guys today. And it is Heart Month, and it is also, of course, Black History Month. And so I'd like to honor that coincidence by mentioning that the first African-American cardiac surgeon in the United States was a gentleman named Daniel Dale Williams, who graduated from Chicago Med back in the 1880s and actually is distinguished by the first surgeon who did technically open heart surgery on a human in the United States in 1895, and that's before X-rays, antibiotics, and general anesthesia. So I don't know exactly what that procedure was, but he is credited with doing that operation. So Daniel Dale Williams first African-American cardiac surgeon in the United States. So I would like to speak about heart disease, and the way to describe what we do as cardiologists is we take care of the heart, which has a number of functions and a number of pieces and parts to this amazing biological puzzle. There is a muscle function to the heart, and of course, diseases that affect heart squeezing function, such as congestive heart failure, affects the heart muscle. There's a plumbing component, which is what I specialize in, is taking care of the coronary arteries that wrap around the heart and supply it blood. And of course, heart attacks are caused by blockages in those blood vessels, which interrupt blood flow to the muscle and then cause heart attacks, which then cause heart muscle damage, and of course, shortens life or can even end it at that moment. Then there's an electrical system. So there are people who have electrical rhythm problems with their heart. The most common one that people know about is something called atrial fibrillation, which causes an irregularity in the heart rhythm. And of course, we have ways of treating that with medication, and there are procedures in which that can also be effective in either curing or getting under control. Then if you look at the heart muscle or the heart as a pump, we talked about the muscle function of the heart. There's also valves through which blood has to go through in order to proceed forward through the body. And diseases involving these valves can happen. And so people have valvular heart disease, where people have had issues with valves that go bad and need to be either repaired or replaced in order to preserve proper heart function. In general, heart disease is a major, if not number one, killer of Americans in this country. About 800,000 people have some sort of cardiac event. It is one of the leading causes of deaths, and about 650,000 people die of heart disease annually in this country, which is quite striking because you hear on the news about all of these COVID deaths, and as we approach 500,000 COVID deaths, I realize that COVID is probably catching up to heart disease as probably the number one killer of Americans, at least this year. So of course, that's number, almost exactly half of those people are indeed women, that women are not exempt or immune from developing heart disease, namely coronary artery disease, and having the same risk of having heart attacks as men, especially after the age of 55, or basically when menopause affects most women. The risk factors for developing coronary artery disease and having heart attack are advancing age, diabetes, high blood pressure, high cholesterol. And namely, when we talk about cholesterol, we talk about the bad cholesterol, which is the LDL number, when they break down your cholesterol or lipid profile numbers. Family history is very important, smoking, and then to a lesser extent, obesity and relative inactivity. So people who live a sedentary lifestyle are at a greater risk of developing heart disease as well. So how does heart disease happen, or how does coronary artery disease occur? When we're all born, most of us have pretty much clean coronaries, and throughout our lives, we can keep them clean by eating a proper diet that's low in saturated fats, exercising, and avoid bad habits like smoking, and probably to a lesser extent, high carbohydrate foods. And of course, there's not a whole lot of things that we can alter with respect to our family history. As I like to joke, how you pick your parents has a lot to do with whether or not you will develop coronary artery disease later in life. But of the modifiable risk factors, high blood pressure, which can be controllable with medications, diabetes, which can be controllable with proper diet and medications, smoking. Of course, smoking cessation or quitting smoking is, of course, one of the best things you can possibly do to extend your lifespan. And of course, getting out and being more active if you can. If you can get out and exercise. And what we recommend is people walk for about 20 to 30 minutes at least every other day. And that would constitute a relatively active lifestyle. And unfortunately, it does not count if you are, quote, active at work and walk around a lot. That never really replaces a good structured exercise program or approach where you are walking, like I mentioned, the equivalent of 20 to 30 minutes every other day. It is surprising who we test on treadmills and the people who say that they are active at work, walking around, particularly with people who are in manufacturing. It's surprising how little that they can actually accomplish on a treadmill, even though they claim to be active at work, walking around on a plant floor and so forth. So, like I mentioned, early on in life, we all have clean coronary arteries. And at some point, somewhere in adolescence, around our teens, we develop what's called a fatty streak. And what happens is in the blood vessel, there seems to be some sort of inflammatory process or some kind of inflammation that damages the inner lining of the heart vessel or the coronary artery. The coronary artery inner lining is called the intima. And this lining gets damaged by maybe tobacco smoke, stress, high blood sugars, which are known to increase inflammation, and things like that. Radiation therapy, so women who've had breast cancer and underwent X-ray therapy to the chest, which involves the heart. Of course, there are breast cancers which radiation therapy can be tailored to avoid irradiating the heart, but there are some exceptions to that. Once this inflammation occurs and damages the inner lining of the heart vessel or the intima, a fatty streak occurs where basically your body, in response to this injury, will lay down what's called lipid macrophages or blood cells that actually deposit fat onto this area of injury and creates what's known as a fatty streak. As you get older, this fatty streak seems to develop into a fatty lipid-laden plaque. And what this is a hard shell covering an ooey gooey cholesterol core. And in that cholesterol core, there is a lot of what we know as LDL or low density lipoproteins, which is your bad cholesterol or LDL. Interestingly, HDL, if you have high levels of the good cholesterol, this HDL actually scavenges the LDL out of the plaque and makes the plaque shrink. So people who have high levels of HDL, in a way, are protected because that HDL will actually act against the LDL and reduce the amount and the size of these plaques that are in the blood vessel. As these plaques develop and get worse, they start to impinge on the blood flow of the vessel. For example, early on, you might have a plaque that's just taking 10% of the space within the vessel, but as it grows, it can get up to about 90, 99% even and start to block the flow of blood. That's when people start to experience chest pain, is when that blockage level crosses a threshold of about 70%. So once the plaque occupies 70% of the vessel, that's when we expect to hear from patients having chest pain when they exert themselves, like go up a hill or go up a flight of stairs. Once after 70%, it gets tighter, 80, 90%. That's when we expect people to start to have chest pain at rest or at minimal exertion. Now, what can also happen is that these plaques can rupture without warning. For some reason, this hard plaque, which covers this ooey gooey cholesterol core, and the way I envision it is like those Rolo candies with the hard chocolate outside in the ooey gooey caramel coating center. It's similar to that, where this shell becomes compromised, probably from stress, high blood pressure, or some sort of inflammatory state. When this plaque gets ruptured, kind of like a zit popping on your face, it releases that ooey gooey cholesterol core to the bloodstream, and the bloodstream reacts to it by developing a blood clot. Almost kind of like if you cut yourself and you start to bleed, part of the healing process is forming a scab. A similar process happens within the blood vessel, in which a blood clot starts to accumulate. And since these blood vessels are very small, oftentimes these blood vessels are no wider than a soda straw or even a coffee stirrer straw. So if you can imagine, it doesn't take very much blood clot to suddenly interrupt the flow of blood down that blood vessel. And that's when heart attacks happen. That's when people start to experience sudden chest pain out of the blue, oftentimes at rest. And when they go to the emergency room, we get an EKG, and oftentimes we can spot where this blockage might be, and then, of course, address it by taking that person to the cardiac cath lab, where we can do a heart catheterization, identify where the blockage is, and treat it by ballooning open the blockage and then deploying a stent to reestablish the blood flow down that vessel. But of course, the most important thing is to prevent that from happening in the first place. So like I mentioned, it is important to manage your coronary risk factors. And just to repeat what those were high blood pressure, diabetes, high cholesterol. Of course, you can't do anything about getting older or how you pick your parents. But if you smoke, you can quit smoking. And if you live a sedentary lifestyle, you can start becoming more active. These same sort of things also apply to strokes to a large degree. So the same risk factors for developing heart disease are almost the same risk factors of having a stroke, which is, of course, interruption of blood flow to the brain, either because of blood clots or because of narrowings or blockages in the blood vessels that wrap or head to the heart from the neck, called the carotid arteries. So heart attack and stroke combined actually account for a high number of deaths and mortality in this country. Interestingly, with women, there is some protective effect of estrogen. As you get older, of course, in women's estrogen levels start to fall. And at that point, the risk of developing heart disease is the equivalent of a male by the age of 55. But before the age of 55, for a non-smoker, non-diabetic female, it is rather unusual for a female to come in with a heart attack. But like I said, after 55, the playing field levels out, and women, for whatever reason, seem to do a good job at playing catch up. And by the age of 70, the numbers are exactly the same as that of men. So with that, I'd like to go ahead and end my talk, and I'll be happy to address any questions that you might have from the audience.
Well, certainly. Thank you, Dr. Kim. That was extraordinarily informative. I am going to go ahead and ask all to unmute themselves if they wish to be heard. What I would like to do is I have a couple of questions that have actually lined up while you were speaking, so you had people engaged. I'm going to ask one question just to get started, but then I would like to turn it over to Mrs. Wanda Moore for a quick testimonial, and then I have some more questions I would like to give you. Would that be okay? Okay.
Absolutely.
So the first question came from our Facebook Live feed, and the question was, I had an EKG done, and it came back that I had a heart attack and heart damage. It also indicated that the age was unknown. How come in this day and age we cannot determine when a heart attack occurred?
The EKG is a snapshot of what your heart looks like at that moment. And there are ways of looking at the EKG that can give us an idea of whether heart damage is occurring acutely, like right as we speak, which would be like in the setting of an active heart attack or myocardial infarction. But then there's also evidence that some kind of damage may have occurred at some point in time. And what we look for in an EKG is something called Q waves. And what this is on these, of course, on the EKG, when you look at the squiggly line, if that squiggly line goes in a certain direction and it's not supposed to, it basically means it may represent that that person has had a heart attack at some point in time, but it will not give us exactly when that happened. In other words, it could have happened a week ago. It could have happened 10 years ago. There's really no way of dating it. It's not like looking at rings on a tree and being able to estimate the date of how old a particular event might have, or when a particular event may have happened. The way we know that is, of course, to proceed with doing either a stress test, which would either confirm or unconfirm, I guess, the presence of any heart muscle damage, because sometimes the EKG can be fooled, or sometimes people reading the EKG can be fooled. And then, of course, the gold standard would be to go on and do a heart catheter, look for blockages, and see if an event has happened.
Thank you, Dr.
Kim.
Kim.
EKG, though, is that
I'm sorry, we're getting background noise again from one of our people. Ms. Wanda, I'm going to put you on mute again and then take you off. We're getting a lot of feedback and having a hard time hearing our speaker, okay?
Yeah.
Okay. All right, sorry, go ahead, Dr. Kim.
Oh, so the EKG also gives us an idea of some rhythm problems, and some of those rhythm problems can look as though people have had heart attacks as well. So really the EKG is not an exact way of looking at the heart as a whole, but it's inexpensive and it's quick, and it's been around for almost 100 years. And so there is a lot of data because people have scoured over these EKGs with fine-tooth combs over the years, and can be able to tease out a lot of information. But still, like I said, it's really just a snapshot of one piece of the puzzle that we use when we're trying to figure things out. But it's, again, only one piece.
All right, thank you. All right, Mrs. Wanda Moore, I'm going to unmute you again. If you would hit the unmute button, and I would love to hear your testimonial.
Okay. Good morning again. Okay, on November of 28 of 2000, I had a heart attack, and I went to Self, and I stayed there 4 days, and then I went to Providence, where I was told that I would be there like 4 to 5 days after my bypass surgery. And then I ended up I had my bypass surgery, and I ended up staying down there a month because they thought they saw a spot on my on my heart. So I had to go back to surgery. And when I went back to surgery, they couldn't find it. And also one thing that Dr. Kim was talking about, we found that mine was hereditary. And another thing that we need to do is when God tells us to do something, we need to do it. A lot of times we don't do what God asks us to do, because if I hadn't did what God asked me to do on November the 28th, I started to stay at home. I said, well, a lot of times we think we'll be all right. I'll be all right to the next morning, to the doctor's office open. But when God tells us to do something, we need to do it. And the reason I said a loving meditation, because a lot of times we go through things and we wonder, why me? Because I was age of 40 and they kept saying, you too young, but I did have a heart attack. We go through things in our life, and the outcome is a great thing, because God shows us things that, we go through to make us stronger. and make her wiser. And we need to, another thing we need to do, which I always did, we need to take our medication. I did that. We need to watch what we eat. I do that most of the time. And it's just a blessing, what, you know, from where I came at, from 20 years ago, where I'm at now, because I don't look like what I went through. So it was just a blessing, with God always blessing us, but we don't see our blessing. I'm trying to think. Well, that's basic, not basic, but that's, I want to keep it short, so we can have time for anyone else have any more questions or answers. But just be thankful and know that you're blessed once you come through something. Don't be upset, mad at people, but you go through things to have a testimony, the things that you have went through. That's all.
Thank you, Mrs. Moore. That was wonderful. Paul, any feedback to her testimony?
That was wonderful, Wanda. Thank you so much for sharing that. There are two things that came to mind, is that very important point that if you do have chest pain or start to have symptoms, it is very important to get attention as quickly as possible, especially if indeed it is a heart attack that you're experiencing, because as the saying goes, time is muscle. And so the faster that a blockage can be identified, and that window is really the first 6 hours. After the 6 hour mark, if you come in too late, like if you suffer overnight or decide I'll just go in at midnight when you started having pain in the afternoon, by then a lot of the heart muscle damage may have already happened and may become irreversible. The amount of time that the heart muscle can be without blood flow before dying, before that heart muscle starts to suffer and die, is about 4 hours. So between 4 and 6 hours, there is this magic window where if we can get blood flow restored, we can save the heart muscle. But after that, it sort of becomes spilt milk. And even if we do open up the vessel, the muscle may not recover. And of course, that may be just one area of the heart, but down the road, that can lead to problems like congestive heart failure, where the heart becomes weaker. The other thing that Ms. Moore brought up was that heart attacks are a big life-changing event. A lot of times, especially in younger patients, that this is the first time that they've experienced a brush with mortality. And similar to a diagnosis of cancer, you go through these phases of shock, anger, grief, and so forth. And then on the other side, of course, we hope that people become reconciled with this and use this as a wake-up call or an opportunity to change their life for the better. And of course, that's, I think, what Ms. Moore alluded to, was that you can take these experiences and make them a positive rather than a negative. So I appreciate her sharing that.
Right. We had another question come in, and you addressed it, you know, talking about that hour time frame, you know, 4 to 6 hours. But let's say that you had not led the healthiest of lifestyles, and you want to make a change. Can heart muscle damage be self-repaired, or is it considered a permanent situation?
So it depends. There are areas, there's a spectrum. So there is a point in time where heart muscle can become scar, and that becomes irreversible damage. But what you can do is to shore up the healthier parts of the heart in order to make up for the part of the muscle that may have been lost. And the amount of recovery or compensation can be quite extensive. We can take people who have really weak hearts and build them up with medicines, proper diet, exercise. And we have a cardiac rehabilitation program, which people really do improve within a 6-week period of time in terms of their functional status and their ability to do stuff. And of course, as you get older, the most important thing in most people's lives is, can I remain independent? Can I live a life in which I don't have to rely on people doing anything for me? And that's the important thing, is to maintain an independent lifestyle. And for a vast majority of people, we can work with them and try to achieve that goal.
All right. We received a message that a participant signed in as caring community nurses would like to make a statement. So now is your time. You are unmuted, so you are free to speak.
Hello, can you hear me?
We hear you just fine. Thank you.
You can't see me. First of all, I've got to say, hey, Dr. Kim, this is Gwen Childs. How are you?
Hey.
Hey, how are you?
Good, thank you. Good to hear from you.
Great. Dr. Kim and I have worked a lot. We worked together at Self Regional Healthcare for many, many years on 7 tires, and my background is cardiac. And I just wanted to make the statement that and with Dr. Kim, all that, he is so right with the things that we need to do for ourselves. And also Wanda was right about doing the things that she needs to do for herself. But we also find out that heart disease plays a large effect in the African-American community. And that's some of the things that I work on, because I have and we are caring community nursing. That's been, I am a nonprofit organization that's here in Greenwood. And we're doing a series of this month every Friday night. We're talking about heart disease and the things that we need to do to take care of ourselves, and the things that are different between, you know, if a woman's having a heart attack and a man's having a heart attack, some of those signs and symptoms can be different. So I just wanted to make the comment that whatever Dr. Kim is telling you to do is correct, and we should do these things even when you're discharged from home. I found out that a lot of times when patients are discharged with the information and the instructions that Dr. Kim has given his patients, it is the follow through that we find out sometimes that patients are not doing. You know, weighing yourself every day. And if you're in that 3 to 5 window, you know, call that physician and say, hey, I've gained 3 pounds in 1 day, so that he will know. And he's right. You will wait. Some patients say, well, I've gained that 3 pounds. I'm just going to wait till tonight, and then I'm going to see what happens tomorrow. And then you've gained 5 or more pounds, and then it's an emergency. When you're calling him, he's going to say, you know, you should have called me minutes before, you know, doing the necessary things, the decrease in sodium, the decrease in water. There's so much that when Dr. Kim's telling his patients, because I'm one of those that were giving those discharge orders to those patients, when he's saying do these things, take these medicines, it's for real. It's a real life change that I think a lot of times patients really don't see what the problem is going to be until there's a real problem. You know, I have heart disease. I've had a heart attack. I'm going home with these things. But then when I go home, I feel good. I feel fine. And then I sort of fall short in the things that I need to do. And then you're still not feeling well. And then we find patients sometimes complain about, well, the doctor didn't do this and the doctor didn't do that. We're not doing our part. So I just wanted to pop in and just make that little statement that, you know, you have to be proactive in your own health. There are a lot of things that you need to do yourself to work with your physician, Dr. Kim, to make you have a healthy lifestyle and make you, you know, able to do some of the things that you need to do post-treatment.
Thank you. So, I think that's a very powerful statement. Absolutely powerful. I mean, it's not just the doctor's responsibility. I would say it's probably 90% our responsibility for our own health.
Yeah, I mean, I would like to think of it as a partnership and not necessarily one-way street. I think one of the dangers of being a physician is that it's kind of perceived as a position of power. So a lot of people don't respond to that feeling like they're being told what to do. And there is an element of denial as well, because this is an organ that's inside your body. It's not on the outside, so you can't see it like a broken bone or something that's out on the outside. You may look completely normal on the outside, but be very much sick inside. And it's sometimes difficult to convince people that they're more sick than they appear on the outside. But it's also, the other thing is that we are going to work with the patient, and try to make them better. And it's not like we're telling them what to do for our benefit. It's for their benefit. And it's built upon a body of evidence that's been accumulated over time. It's just not our opinion. It is truly evidence-based and science-based.
Yeah. We had a comment that came through from Brenda Holland Curry, and it's got me scratching my head. She said she's referring to Wanda's testimony that she had a heart attack 20 years ago. And Brenda says, praising God that 20 years later, that Wanda is still alive and well. She's a great friend. Thanks for inviting me. So that's a very nice statement, but I find it hard to believe that Wanda was 40 years old 20 years ago. That math isn't adding up. There's no way that statement can be true. Ms. Wanda, would you like to reply?
Yes, it have been November 28th of 2020. It was 20 years ago. I'm not ashamed to tell my age. I'm 60 years old, and I have a birthday coming up. And it's just by the grace of God that I'm still here, and I still can, testify for what God have did for me. And another thing that they was talking about, all heart attacks are different. Everybody said, well, I didn't have this, I didn't have that. When I had my heart attack, it's a strain. Felt like something was sticking me in my throat, going through my back. Like I said, I've never heard that before, but that's what it was. And then another thing, everyone's different. So just because we say, well, I don't have no pain going up my arm, you're not the doctor, you're not God. So go on to, go see about yourself. Sometimes we can be hard-headed. I used to be hard-headed about things like that, but I'm not. And we need to exercise. We get up and go exercise every morning. We be at the Y at 5:30. So we don't say, well, I'll do it that afternoon or whatever. Go and do it that morning, because that afternoon you'll be thinking of an excuse why you're not going. We just got to do for ourselves, and we always think about what other people can do for us, but we need to do things that we know that is right, and we know our body needs it.
All right, we have another question that has come through. Has there been any indications in the research lately about those who have contracted COVID and come through it, about any lasting impact on heart health? Is there anything that you're seeing out there that we should be aware of? We do have quite a few COVID survivors within our group.
It's really too early to tell what the long-term effects of COVID will be on both the heart and the lungs. So oftentimes, a lot of residual shortness of breath has been really difficult to figure out whether this is related to lung disease that is a consequence of the pneumonia that a lot of people with COVID-19 have developed, or whether the virus itself has attacked the heart muscle and made it weak. One of the things that we have also seen is that people come in with heart attacks and have tested positive. And it's sometimes difficult to tell whether that's the chicken or the egg, whether the COVID-19 was just a bystander and people were just coming in with heart attacks and happened to have COVID-19 at the same time, or whether the virus had anything to do with the development of the heart attack, whether that's because of the inflammation that the virus caused, or whether there's a situation before the heart attack actually could come as a direct consequence of the infection. And that's been difficult to see this early on. And fortunately, Greenwood, we haven't had enough cases to be able to pick up a trend in one way, shape, or form. I think at larger centers in bigger cities, I think it's easier to see waves of things happening. And so I think that data will come down the pipeline within the next year or two, and we'll be able to see. But what does frighten me is that there might be some consequence of having COVID-19 that won't be readily apparent until 5 or 10 years down the road.
Right, right. I've got one more question, but before we hit that, I'm going to offer my own quick testimony. Early on in your presentation, Dr. Kim, you mentioned about electrical signals affecting the heart, and it's not just heart attacks and clogged arteries. My wife in her late 30s had suffered from seizures all her life. And it was thought that maybe she had epilepsy, et cetera, and they just couldn't find anything. They'd even given her some anti-seizure medicine, and it didn't seem to make any difference whatsoever. In her late 30s, while donating blood at work, she had a massive seizure. And it looked just like an epileptic seizure. She went unconscious. She was shaking and moving about the floor. She went in a week later, and where they tried to induce the seizure, they hooked her up to every machine known to man in science and induced the seizure right then and there. And they were able to pinpoint exactly what it was. She got a call, it was from your firm there, Dr. Kim. It was from one of your colleagues who's moved on to Rockville, but he called almost excited, saying, "Come in, we know what it is." And what it was happening is that there's a natural body reaction that when you start to feel faint or whatever, your blood pressure drops and your body kicks into some survival mode. Well, her heart was going overdrive. And in fact, it was overreacting to a point where she was actually experiencing heart stoppage, and the seizure was just her body trying to jumpstart the heart. And so they were actually able to see, when they induced her seizure, her heart flatline for 20 seconds, I think was the number, was around that time frame. So the quick fix for that was a pacemaker. So at the age of 38, she had a pacemaker inserted right there at self, and she has not had a seizure since. So anytime that she gets that condition, the pacemaker kicks in, regulates the heart, keeps it ticking, and she's not had a seizure in the last 6-7 years.
Wow, that's amazing.
So it's really, you talk about it being different for everybody. That was just, one symptom that we never would have thought was heart related.
Sure.
All right,
it takes a lot of convincing to have a young woman agree to have a pacemaker implanted. So it's I guess kudos to her for taking that leap of faith.
Yeah, she does say that she joined a Facebook group for pacemaker support. And she is by far half the age of everybody else who's in that group. So she was able to get over it and got good information. And, her ticker is ticking ever since. The last question that we have in our queue involves HDL. And you had mentioned LDL and HDL, HDL being the good and the LDL being the bad, roughly speaking. And this question is coming from me personally. So I get biometric blood work done every year through my company. And every year since I can remember, going back dozens of years, my HDL has always been low. And no matter what I do, I have not been able to get it up to the level where it needs to be. What are legitimate ways to increase HDL? Like, I hear fish oil pills. I tried it. I don't know if it really worked or not. Didn't seem to change my number. What's your opinion on HDL and how to get it up?
So HDL is one of those numbers that is probably 90% genetic and only 10% modifiable. Unfortunately, there is not a single drug that will target HDL and increase it. One thing that does do that is estrogen. So that is one of the protective things of why we think young women are protected, is because estrogen levels, high estrogen levels or normal estrogen levels, will bump up that HDL level and offer that protection. But we can't, of course, offer that to everyone, including men.
Yeah, I'm going to say, if you're suggesting I take estrogen pills, I'm going to say that's a hard pass.
No one said no one ever. So statins can increase the HDL only modestly, maybe about 3 or 4 points, with relatively high doses of cholesterol medications like Lipitor or Crestor. Fish oil capsules taken in fairly large quantities, like 2 to 3 grams a day, may increase that HDL level by up to about 5 points. So again, HDL usually runs around 40 plus or minus. And a lot of people with low HDL numbers run numbers in the 30s and even in the 20s. So we're looking at maybe increasing it by 5 points, 7 points at the most. The best thing really is exercise, and not just the 20 minutes every other day thing, but probably a more rigorous exercise program will increase that HDL quite substantially, probably by up to 10 points. But it requires quite a bit of a commitment to exercise and fitness to get those levels and maintain them. But unfortunately, this is another situation where HDL is one of those parameters in which your genetics has a bigger influence over than any other thing that you could do from the outside.
All right. Well, thank you, Dr. Kim. That was it for the questions in the queue. Wanda, would you like to offer any last comments? And we will wrap it up for the morning.
I just want to thank Dr. Kim for all the great information. And let's use that information. He wasn't up on Saturday morning just to hear himself talk. So let's use all this information that Dr. Kim had given us. And also I want to thank Bill Kimmler and Ms. Cheryl Morton for your help with putting this together. This is the first time I've had to do something, get it together on Zoom. But with y'all help, we got it together. I just want to say thank you, and I appreciate it. But like I say, this is something dear to me. And let's just take it all in. And thank everyone that came in. I know several people told me they would have to go back and look at it later, but I just want to thank y'all three for whatever you did to help us with this heart awareness.
All right, with that, we will end. This recording is going to be available on Facebook. So if you go to our Facebook page, you can watch the whole thing in all its glory. We'll also have a cleaned up, edited version available on YouTube. So we'll send that link out to all participants as well as put it in our newsletter for those who want to watch it later. Thank you again, Dr. Kim. It was awesome to see you again, and we'll catch you around. Hopefully not in the hospital, in a more social setting.
Bye, Miss Moore.
Bye.
Bye-bye.